think there's Marie. Hi, Marie.
Good afternoon. How are you?
Doing well, doing well.
Good. It's just now 12:30, and I think there were maybe one other physician had let Brandon know, so we'll give it a minute if that's okay.
Sure. No,
Um,
you tell me, and when we're ready to go, we'll jump right into it. I want to make sure I'm cognizant of everybody's time, and
Very good. See, Dr. Anhalt's on.
See if that day comes. I doubt it. Yeah, it's more than just us.
Well, why don't we go ahead and get started to respect everyone's time and
sure.
go from there. Okay?
Thank you, Marie. I appreciate it.
Well, thank you. And Brian, I'll turn it over to you. For those on the phone who've not had the opportunity to hear Brian before, Brian represents Freedom Healthworks, and Freedom Healthworks reached out. NPO reached out to Freedom Healthworks as part of our steering committee and looking for resources to learn more about DPC, and then for those physicians who may want more help or understanding or more support, Freedom Healthworks can assist with that. So with that, I'll turn it over to Brian.
Thank you, Marie. I appreciate it. And like Marie said, this is our second in an installment of two, and more than happy to have more of these. It's a lot of fun for me, and hopefully it's educational for you all. Let me go on a video here, and I will start to. You tell me if you can see that, Marie.
I can.
Perfect, perfect. So real quickly about myself, just for background purposes, I've been in healthcare, oh gosh, for over 30 years, and not as a practicing physician, but one that's worked in the technologies of identity matching and data analytics. And I've worked in a number of different situations with technologies that affected the registration process, the HIM, revenue cycle. I've worked in the Department of Health on a number of occasions in many states. So it's really taken me over the course of those times through the payer, the provider, the patient, understanding care coordination a lot. I worked for a time with Johns Hopkins on their predictive analytics platform, helping understanding comorbidities and care coordination within communities that serve the provider nation across the country. So that was fun. So really today, my goal is to really help you understand really what DPC is and define it a little bit more with a little bit more granularity. And when we did the call last on the 20th of May, there was a number of questions that came up. So I've kind of tailor made those to direct to some of those questions because some of those questions that came out of our earlier webinar are probably the same questions that you're going to have as well. So I want to make sure I touch upon that. But the goal today is just to be informative, right? Is to define DPC, understanding where Medicare plays in the DPC world. What does the DPC world look like to patients if you go down that direction? And then if you end up wanting to go down the DPC route, what does that look like from a group or a solo type of a move on your own? So with that in mind, I've kind of broken it down into these 5 segments of defining it, what DPC and Medicare, how do they coexist or do not in certain ways in the transition, the patient impact, Also, touching upon your TIN, and what does that look like? Do you have to set up a separate entity if you go down that route, depending on what you're practicing? And then kind of the 4 pillars of, if you go down that path, what does it look like? How does the structure look like from a business formation and marketing and such? And then obviously, we're here to support you any way we can. So one of the questions that came out of our original webinar on the 20th of May was DPC versus concierge. So DPC as a whole is just a membership-based model in which the patient pays the physician a flat monthly fee for comprehensive primary care. And it's bypassing the insurance that you would normally have in a primary care relationship. That's really the gut of what DPC is. You have a membership fee, you have a that's been determined for that market that you're in, that you help determine and place, as well as maybe with some support from others. And then you have a monthly fee, and depending on what those services wrap into for that monthly fee. So that's the structure in a whole. But at the bottom line, it's basically getting rid of insurance. And concierge, medicine, it's a layer of membership fees on top of insurance billing. So in concierge, it's just kind of a fancier title or a fancier way to say, hey, I'm going to, see folks on my own, but we're still going to go down the insurance path, and we're still going to code and bill and collect, from the payers. So that's where that separation is. So I wanted to make sure that there was a little bit of understanding of where that is. Direct primary care replaces the third-party payment relationship, for primary care entirely. And so, again, as I mentioned, the patient pays the practice a flat monthly fee, and that's really going to cover the defined scope of primary care services. You're not going to have any claims. You're not going to have any co-pays for the patient. There's no coding for covered visits, no payer interference in the treatment plan. And really, the panel sizes are going to drop typically from what you're possibly experiencing now. And again, I don't want to be, I want to be generic in nature, but not, categorize everybody in the same bucket. But there's practices, obviously the panel sizes could be 2,000, 2,500, or more, depending on where you are and what services you're offering currently. And that's going to drop significantly to probably anywhere between 400 to 600. And again, if you structure the fees and you structure the membership fees around it, you're going to have a nice income replacement by going this route. And what it's going to do, and this is the conversations I have with people that come to me and say they're thinking about DPC, is the reasons are the same that I hear. It's just the timing and the location are different. But the same reasons that I hear is I want to spend more time with patients. I do not get to do that anymore. I love practicing medicine. I want to continue to practice medicine, but I'd like to spend more time. And I feel like it's a cattle call. And I've heard that term before. And I also, want to be compensated for the time spent. But I also want to have a quality of life and a quality of time spent. And a lot of times, depending on where an individual is that I speak to, sometimes it's, hey, I want to spend more time with my family. My kids are young, or my kids are grown. I'd like to travel a little bit more, spend more time with others. And so everybody has a different perspective on what kind of gets them to think about this direction. But ultimately, it's the same story. It's just a different bent on where that person wants to be. So I think at the crux, that is probably as bare bones, as simple that I can put in process of what a DPC model and a DPC primary care looks like. And I will tell you, and hopefully you're not taking, notes and writing fast on your lunch hour here. I will give this slide deck to Marie and Brianna, and they can distribute it amongst everybody that shows up today. So,
Brian,
yes,
hello?
yes, yeah.
Oh, I think I just want to add to your statement you made on DPC in terms of having more time with patients. DPC also affords the physician and patient to decide the best method of communication. It doesn't always mean the patient has to come in for a visit. You can have longer visits, but you could also do subsequent follow-up or calls via telephone, telehealth. So it's not always about capturing that visit needed for billing because it's covered under the subscription. So that gives so much more flexibility. So I just wanted to add that.
No, good point, and I appreciate you doing that. And Marie, you're 100% correct, because and again, it allows the physician to set the rules, because again, you know, and I'm not saying something out of school or something you don't already experience, but you know who your patients are, and you know what patients are a little bit more high maintenance than others, or some need to have a little bit more discussion than others and spend some more time with others, and some that would like to text you or, you know, call you later at night or something if they have an issue or something like that. But it allows you to set the terms. It allows you to be able to do that. So that really falls on the physician to set up the parameters of what they see fit and choose. So again, excellent point, Marie. It's not always face to face. It's telehealth. It's texting. It's FaceTime. It's whatever mode of communication that you would like to set up to run your practice. So perfect point. And again, in the realities, again, which I stated earlier, insurance-based reality versus a DPC model, 100% in the opposite directions. One's going one way, burnout, attrition, documentation, short time, where the other one, longer time, better patient care, I feel, better patient interaction, transparent pricing, and a sustainable revenue model. So this question comes up quite a bit, is where does Medicare and DPC play in the world together? And can they coexist? And they can definitely coexist. There's a couple rules, bear in mind. And you can have kind of a hybrid carve out in the fact of Medicare, and you can remain enrolled in Medicare, but you have to structure the DPC offering so the membership fees only cover services Medicare does not, because that's a huge legal aspect of it. And so you've got to have that very transparent, and you have to have that stipulated in the contract with the patient. So that really has to be careful service level documentation and patient agreements. And these are things that we do, obviously, to help you. But I just want to make it clear that it does coexist. It can coexist. You just have to be very clear up front with the patients of what fees it covers, and for the membership that you're charging, and what it doesn't cover. And then obviously the other aspect of it is the opt-out of Medicare. And quite honestly, here's what we see over time: you have a kind of a hybrid model, and then over time, I think we see probably maybe 70% plus, 80% plus, where Medicare just kind of goes away. It becomes something that the physician just doesn't want to deal with anymore. And it just kind of goes away. And obviously that's the highly recommended aspect of it, but it's not the rule. And like I said, they can exist coherently together. But if you do opt out, you just file a format opt-out affidavit, and you enter the private contracts with the Medicare eligible patients, and it's the cleanest separation that you can have, but no Medicare reimbursement for any services during that opt-out period. So that is probably, like I said, one of the main questions that comes up. Like I said, most physicians who plan a long-term DPC practice eventually conclude really that formally opting out of Medicare and the 2-year opt-out election with private contracting, or switching, or the ordering and certifying, is really a cleaner path. Because what it does, from what we see and from what the physicians end up understanding, is that it really removes the ambiguity, and it simplifies the compliance and lets really every patient, Medicare eligible or not, receive the full membership. And we see that our best practices is really running a long-term DPC practice. For the time and energy spent and the compliance and the overlay, it's just a lot cleaner. So wanted to make sure we were able to discuss that in a little bit further detail, because that was one of the key questions that came out of our last webinar. And again, there are guardrails.
And just to add to that, Brian,
Yes.
So there's the opt-out option, and then the option with the hybrid, still seeing a patient in a DPC program, Medicare patient in a DPC, but being very clear on what's covered and not covered. And really, there's another third option, and correct me if I'm wrong, Brian, is if Dr. X wants to start a DPC program and does not want to opt out of Medicare, he can elect not to enroll any Medicare patient into his DPC, and thereby keeping it very clean that way. So he's still a Medicare participant, just not seeing any Medicare patient under the umbrella of DPC.
That is correct, and that's where that membership, and the transparency documentation come into play.
Right. Okay.
Yep. Absolutely. All good points. And kind of already went through this already with some of the compliance issues and the guardrails that take you down that path, because you want to make sure there's obviously no double billing and the service level separations and clear patient agreements, which we just kind of discussed here a second ago, and the opt-out affidavit timing. So every state's a little bit different, but most states really have an explicit DPC status that exempts DPC from insurance regulations. So you just want to work within your state framework. And again, those are things that we can help out if and when that becomes an issue. So from a solo perspective, what does this look like? And if you said, hey, I kind of want to tip my toe in and see what it looks like if I were to go down the path of a DPC structure. So, and I'll give you an example. So obviously you have to work on your exit strategy, and depending on where you're coming from, and everybody's different situations and organizations they currently work with. But you've got to work on the timeline. You've got to find out, patient notifications and buyout provisions, and when to opt out of your contract or what have you within the organization. I'll just throw out Henry Ford, for example, because it's Michigan, but but you do that. And then what you want to keep in mind is give yourself typically about a 6-month lead to start this process, because you want to give yourself plenty of time to establish a potentially new brick and mortar location. If you don't have a location, or you're working out of an existing location, that speeds things up a little bit better. But there's a lot of things that go into play from the standpoint of understanding the market and how to price, setting up your own separate TIN or your own new entity for your practice. And if you are in you're in a group where some are practicing currently the way that everybody's practicing with insurance base, but yet you want to be a DPC under that, you want to make sure that TIN is clearly isolated, because you want to make that separate from the TIN from the others. And Marie brought up a great point. She brought up the terminology of moonlighting, which I thought was an excellent point, because if you have somebody under an umbrella or under the roof doing DPC, you want to make sure that there's, location 1 and location 2. They want to be separate legal entities for that. And that was one of the questions that came up last webinar. So the Medicare and the payer clarity, you want to make sure you're not mixing non-participating cash pay practices under the same tin as an insurance billing practice, because again, you're going to run into potential compliance risk and around the assignments and balance billing and so on. So you want to make sure that that separate tin cleanly isolates the DPC entity from those other obligations. And when you're setting up a solo practice, you have to bear in mind you've got marketing, you've got logos, website, documentation, vendor relations that have to be set up, a new EMR relations, or you may have an existing EMR that you can use as well within underneath a current setting that you might be able to do. So you might not have to go down that way. But so these are things that are possibilities depending on everybody's situation. If it's a clean break and you're going from, say, a Henry Ford and you're starting up your own, then you don't have access to share an EMR, and you don't have access to share vendor. So those come into play, and we help obviously facilitate that. But you're talking vendor contracts are probably 3 months sometimes to get those organized. Your marketing, your website, your branding, all those types of things, your demographic and socioeconomic research for the marketplace that you're in. That takes a little bit of time to understand exactly what to charge and what that membership fee should be compared to what that services fee to be. And I use this as an example, is that someone in Northern Virginia can charge something specifically different than somebody more outside and maybe south of Richmond, Virginia. And because, again, if you're in that Northern Virginia, it's a pretty populated, highly, financially higher range of folks, and you can pull from the DC area as well. So you're pulling a higher income level in and around that vicinity. It could warrant obviously a higher price. So again, these are things you just have to keep in mind, because at the end of the day, you don't want to overprice, but you don't want to leave money on the table, because again, you're doing that income replacement. You're looking for that patient panel that really fits that need for you. And everybody's different. And we say 400 to 600, folks, depending on where you are in life and lifestyle, you can play with that number. So some people say, hey, I'd like to do 600. And I don't want to do more than 250. Everybody's situation's a little bit different. So you want to get yourself in a situation where you're getting all the foundational aspects and infrastructure completed prior to the actual day you kind of open up the shingle and hang it on the front of the building per se. And that's about a 6-month lead. We have seen it do a little bit quicker, but we just automatically recommend 6 months.
So Brian, with the slide that you currently have up, if you don't mind just going back just a bit there. Yeah. So just to restate, if a solo practitioner, so let's say a physician in a larger practice would like to do DPC, there are the two options as you described. Plan your exit structure, take that 4 to 6 month window, 6 months if you're getting a new site going as well. But if somebody wants to remain a part of that larger practice, they can do so because they will have a separate TIN and their NPI would be coordinated with their new DPC TIN. But if that physician would like to also cover back at the larger practice or moonlight, whichever way we want to define it, they would have still their NPI TIN relationship with their original practice established. So only the new TIN is not associated with any insurance, or maybe just Medicare, let's say that, but just to simplicity, no insurance with their new TIN and their NPI relationship, but yet they still have their existing TIN, that they're currently a larger practice, an NPI relationship. So that practice, if they're covering that week, can bill those insurance companies that physician sees. I mean, when he sees those patients with that insurance. Does that make sense?
Absolutely. No,
Okay.
absolutely. And the thing, kind of going a little bit beyond what you just said, if you're in an existing practice, now you've got shared services, right? So you have the ability to kind of shorten that window of 6 months, because again, you're being able to share some of those services from a vendor and EMR perspective as well. But again, it's all based on the relationship that is taken care of within the organization that you might want to move into, or maybe existing, and how that flows. But that is an advantage from that, and it does shorten up the window.
Thank you.
So patients, one of the questions that came up is how does it affect my current patients, or how does the DPC impact a potential patient, new patient, or maybe my existing patients? And quite honestly, the patient impact, if you're coming over from an existing practice and you're going DPC, because again, it's a paradigm shift. It's a mind shift from a typical insurance-based line of thinking to a cash-based line of thinking. And so there's a lot of education, there's marketing and discussions in there between physician and patient. And again, those are things that we support. But typically we see about an 8 to 15% of the existing panel converting in the first 12 months when physicians are actively communicating the change. And then, you'll see another percentage of anywhere between 5 to 10 converting in year 2 as word of mouth builds and people talk and they find out how, if I can make a call on a Monday, I can go see somebody on a Tuesday and not 2 weeks or 3 weeks later, or I can place a phone call and I actually get a phone call back, or I can do a text or a telehealth call and I can do it in the same day. I mean, all these things are advantages to the patient. And, the conversion rate is driven less by really demographics, but really how it's articulated and marketed within the community that you serve or wish to serve. And then, there's the vaccines and the labs and, LabCorp request imaging options, to nearby hospitals for cash pay rate. Those are all opportunities for the outpatient if you're using an outpatient imaging department, for example. So those are all opportunities out there from a patient responsibility. And again, if you're doing patient impact to your folks that you are caring for now, and then obviously from a responsibility standpoint, under a DPC model, hospitalizations, emergency cares, they need to maintain, and then specialist cares and referrals. And I'm sure that would come through the physician and the DPC discussions as well from that perspective. But imaging and labs are not included, but or wholesale price through the practice, and the medications outside of the in-house pharmacy. And we have a Dose Direct is our vaccine entity within Freedom Healthworks, and pretty much covers everything that a DPC practice would need. But again, for those that are outside the medications, there are opportunities out there for them. But anything outside a defined primary scope of your membership agreement, and it's again detailed very specifically in the membership agreement. So it's laid out systematically, fully transparent for that. And we see, most DPC patients pair their membership with a high deductible health plan or maybe a health share ministry, for example. And we provide really patient education materials to kind of make that distinction and explicit. to help them understand that the ability to have better care, more time, interaction with the physician, and also to have the ability to be seen and really save at the end of the day. Because again, and I've been in this world now for many years now. And if you think back, and again, I had to kind of go through this with my wife actually, and I'll use her as an example, which she probably I always use her for examples for a lot of things, but it's a good example from the standpoint of a paradigm shift. Is that, gosh, we have this card. Why would we want to do this? And if you break down the cost, a lot of times now with high deductibles for insurance plans and how much they have a patient has to pay for those high deductible plans, and what's taken out of their paycheck, conversely to the scope and care that they're currently getting, and the time and effort and then the hassle with the insurance and so on and so forth, compared to a DPC model where typically it's considerably less for all the services and the membership fees that they get, that really 80% of what they need can be easily taken care of. And then outside of that extra 20%, depending on the individual's health status, that's where that extra high deductible policy would come into play. And so it's a really fast and growing segment. And I've heard more people, obviously, and it's easy to get complaints about insurance companies. It doesn't take anybody any time to be prompted to talk, about insurance issues. But I've seen and heard a lot of the physicians at the same time talking about the ease of kind of getting that burden off of that, and just, again, spending more time and taking care of the patients, and knowing full well that they're getting the value for their dollar. So when we go to the 4 pillars, and again, we talked about this already, but you've got to keep this in mind from an individual perspective. You've got launch, operations, your intelligence, and your growth. So those are all key factors. That the launch and the operations are on the front end. The intelligence kind of comes in the middle of that beginning launch in first year, and growth is just a continual. It just depends on how much you want to grow from where you want to be, or where you currently are, to where you want to be from a lifestyle perspective. So again, we look at it from about a 6-month process of building out all the foundations and activation, and really from day one of opening. And again, it's kind of what we do. I mean, we've been doing this for 10 plus years. We've opened up a lot of practices over the country, and obviously we're in 38 states. And our goal is to grow the DPC model for those physicians that want to move toward that direction. But we're also here to help and answer questions, and really be a kind of a thought leader in this area, and really address those physicians that are looking or potentially thinking, is there something different out there where I can kind of go back to why I got into this field initially from school. So with that, I want to be cognizant of everybody's time and lunch hour. So I think we've got in there the 30 minutes. And so I want to make sure that we are good.
I think we are, and I just want to thank you, Brian. And if I could go back, you don't have to bring the slides up, but in terms of patient responsibility, most patients still they all still carry insurance for that catastrophic event.
Correct.
But the experience and some of what we're seeing in our market, are some of employers are encouraging or actually covering sometimes the subscription fee. Plus, the health savings accounts in Michigan are now allowed to cover the subscription fee as well, with the goal of getting patients greater access on their timeline, helps the employer, employee, and hopefully, especially those who are self-funded, they're not spending the very expensive care at the hospital and ERs if patients have access to their DPC. So
that is correct, Marie. And like I said, the more conversations that I have, the more I'm seeing employers stepping up, and really, especially in those 40 to 30 employee less type businesses, where they might have a handful of people that they really want to take care of, and they know that they don't offer, insurance, a full plan insurance to those people, but they want to take care of them. And so we're seeing a lot of organizations and businesses step up and either give them a stipend or toward the membership. They either pay the membership or they're paying their monthly services in their paycheck. So there's a lot of talk about that, and there's a lot of growth and a lot of excitement around that as well. So absolutely, you are correct on that that point, Marie.
Well, thank you, Brian, and thank those. I think Dr. Anhold had to step off the call, but we'll follow up. And if there are any additional questions, again, send those to me. We'll get some answers. And then if any of the physicians wish to proceed, we can, with contemplating DPC and that business plan, also let me know, and then we can continue to work with Freedom Healthworks to help get some of that understood and those next steps.
Absolutely. And I will forward this slide deck to you, Marie, so you can distribute to the group. And like I said, we're here to help, and please direct those questions to Marie, and I will follow up with her and get those addressed for you as well, and get those sent out.
Thank you.
Take care. Thank you very much.
You too. Have a good rest of your day, everybody.
Thank you, everybody. Bye-bye.
Bye.